If you had back surgery and you're still in pain, you're not imagining it and you're not alone. There's even a clinical name for it, failed back surgery syndrome. We're here to explain it scientifically, why the pain so often persists, because once you understand the biology, a lot of things start to make sense. Because there are a handful of things almost nobody explains before or after that surgery, 5 of them specifically. At Regen House, we spend a lot of time on the science of why back pain behaves the way that it does, and this is one of the most misunderstood situations in all of it. So we're going to walk through 5 things almost nobody tells you about back surgery, how common failure actually is, why a repeat surgery gets less likely to help each time, why the surgery only targets one structure of an interconnected system, and how fusions can wear out the segments above and below it, and where the pain may really be coming from. And then we'll explain where regenerative medicine fits into all of it. Let's get into it. Let's define it plainly. Failed back surgery syndrome, M96.1, is officially called post-laminectomy syndrome, but spinal fusions fall into the same category too. It covers overall back surgeries including laminectomies, discectomies, and spinal fusions. It's simply the term for persistent or reoccurring pain after spinal surgery. But what actually causes failed back surgery syndrome? Or why can it happen? So here's the first thing. It happens so often that it has its own official diagnostic code. In the medical coding system, every diagnosis runs on it. Think about that. This outcome is so frequent that the system needed a dedicated code just to track it. And the numbers back that up. Failed back surgery syndrome can happen in about 40% of all back surgeries. And with the complexity of the procedure, that number can climb up to 50% for spinal fusions. So if this is you, and you're very far from alone, this is a documented, named common outcome. Let us give you a real example of how openly this is understood, even by surgeons. We had a patient whose good friend was an orthopedic surgeon, and that surgeon told him honestly, if we went ahead and did the back surgery, he'd realistically expect to see him back in about 2 years because the first surgery would lead to more surgeries in the future. So here's the question we'd ask you. Were you told that a back surgery can carry something like a 50% success rate? And knowing that, would you still do it? So here's the second thing, and it follows right on from that. When a back surgery doesn't work, the natural next step a lot of people are offered is another surgery to fix it. But the odds get worse each time, not better. By some estimates in the published literature, a first back surgery has a roughly 50% chance of giving the relief that patient was hoping for. Think about that for a second. The first one is essentially a flip of the coin, and then it drops. A second surgery is successful only around 30% of the time, and a third around 15%. A fourth down around 5%. Each operation is working through more scar tissue in an environment that's already been altered by the last one, which is part of why the odds keep falling. We're not saying surgery is never the answer, because sometimes there are situations where it is. What we are saying is that once you have a surgery, you can't undo it, and you can get stuck on this track of constant pain and more surgeries. This is one decision, the decision to have surgery, that can truly alter the course of the rest of your life. Here's a third thing. When you have one of these surgeries, you're only targeting one structure, but your spine is a complex, almost orchestrated system. Every part of it has to work together. So when you affect one thing, you're then going to affect other things around it. It isn't simply that a bone or a disc is pressing on the nerve, and it isn't simply that the spine needs to be fused because it's unstable. When you do a surgery like that, you're treating the spine as if it's in separate pieces that don't work together, when in reality, they're completely interconnected. And that's the part of the reason these surgeries fail, because the reason you're having the pain usually isn't just one thing, it's coming from multiple sources all at once. And those sources aren't being addressed by a single laminectomy or discectomy or a spinal fusion. You have to figure out what is actually generating the pain and how to address that so it holds up long term. The fourth thing mostly applies to fusions, and it has its own name, adjacent segment disease. Here's the logic. Your spine is built to move, and that motion is shared across a whole stack of segments. When you fuse vertebrae together, whether it's 2 or in some cases we've seen up to 5 fused, that fused section can't move anymore. So the motion and the load it used to carry gets redistributed to the segments directly above and below it. Those neighboring segments now work harder than they were ever meant to, and over time they can wear out faster because of it. And this isn't rare. In the published research, roughly a quarter of lumbar fusion patients show adjacent segment degeneration on imaging, and a meaningful share of those develop actual symptoms from it. And the risk climbs with each additional level fused. So multi-level fusions carry a notably higher chance of it. So in some cases, the surgery addressed the original level, but set up a new problem 1 or 2 segments away. That is documented, named, and it's a consequence that deserves to be a part of the conversation before anyone signs up for a fusion, not discovered years later. Here's the 5th thing. We're circling back to what we were saying before about your back being an entire system that's so interconnected. That is honestly one of the main reasons back surgeries fail and why revisions end up having to happen. Around every spinal segment you have the disc in between, the facet joints behind, and running along all of it the paraspinal muscles, the deep muscles that stabilize your spine. And here's what almost no one tells you. When there's a problem at a spinal segment, those paraspinal muscles go into a chronic protective spasm. It's called splinting. Your body clamps those muscles down to guard that area, and it doesn't let go. Imagine the damage that gets done to those muscles with years of that protective spasm, years of that splinting. The physiological damage that happens to not only the muscles, but the entire spine. Don't you think that would cause a tremendous amount of pain? Possibly even pain, more pain than the original disc problem itself? This is the piece that almost never gets talked about by your spine surgeon, and it may be one of the biggest drivers of the pain. Now think about what that splinting does mechanically. Chronically tight paraspinal muscles put constant compression load on the very segment that's already irritated, the disc and the facets. So the muscle tension isn't just a symptom, it becomes its own pain generator, and it feeds back into the structures underneath it. And this splinting frequently extends 2 or 3 segments above and below the original problem area. So it's a much wider zone of tension than the single level anybody operated on. Now bring the surgery back into the picture. To reach the spine, that surgery had to cut through and reflect those same paraspinal muscles, disrupting the muscle architecture to get to the target. So after surgery, you can end up with a segment that was mechanically worked on sitting inside a wider area of paraspinal muscles that is still splinting, still under chronic tension, and now also dealing with the trauma of the surgical approach itself. The disc got the attention, the muscle system around it, the thing that may have been generating a large share of the pain, often did not. If this is the first time anyone has actually explained the mechanism to you instead of just naming it, subscribe. This is the kind of science we walk through every month. And drop in the comments whether you've dealt with pain that lingered after a procedure. So those are the 5 things. Now, since we're a regenerative medicine practice, the fair question is, where do stem cell derived therapies actually fit in? Here's what actually happens at the tissue level. Those chronically splinted paraspinal muscles and the fascial tissue wrapped around them are collagen-based, specifically type 1 and 3 collagen. And that collagen-based tissue, worn down by years of splinting and microtrauma, is exactly the kind of structural tissue that collagen-containing stem cell derived therapies are studied for supporting. The umbilical cord tissue, named Wharton's jelly, carries that same type 1 and type 3 collagen, the raw structural building blocks. So when a collagen-based stem cell derived therapy is applied locally to those paraspinal structures, the biology at play is twofold. 1, the signaling in these therapies is known to help modulate inflammation in the local environment, calming an inflamed, irritated area. And 2, by supplying collagen building blocks to the worn fascial tissue, the environment supports the body's own collagen repair process, what the science calls collagenic differentiation in that local tissue. As that fascial tissue is supported and some of that chronic tension eases, the compression load those tight muscles were placing on the segment can calm down. That is a local, mechanical, biological explanation, and it's a very different thing than claiming we healed the disc or reversed the surgery. So here's something worth doing. If you're considering back surgery or even a revision to a back surgery you've already had, get a second opinion from someone who's not a surgeon. And this might sound obvious once you hear it, but a surgeon's specialty is surgery. So a surgeon is very likely to recommend a surgery. Getting a perspective from outside that lane can give you a fuller picture before you make a decision that's permanent. So here's our question for you. If you've had back surgery and the pain has lingered, did anyone ever actually explain to you where it was coming from? Drop it in the comments. We read them and it tells us what to explain next. Subscribe for the kind of education that helps you actually understand your own body. We'll see you in the next one.